So I've been asked to talk about another proteasome inhibitor. This time we're talking about an oral proteasome inhibitor called Ixazomib, or if we can use the name they just got in the US, it's called Nilaro. I don't know, I think we'll go back with use Ixazomib. I don't like Nilaro, honestly, not very easy to say. Anyway, I know Dominique mentioned already what the proteasome is, and I want to just give you my version in a way. So the proteasome is this enzymatic complex which is inside the cell when actually you use to destroy what is produced in excess in our body. This is mainly protein that being degraded, protein they need to be destroyed in our body to keep the protein homeostasis. And you can easily imagine if you plug this garbage bin, in a way, the protein actually gets stuck inside this complex. And this is something cells don't like at all, especially cells like myeloma. They produce a lot of protein. So you can imagine if you stop this degradation of protein, the cells actually are they get full of this extra protein, and this disturbs some of the key signal important for myeloma to grow, and this led to myeloma cell death. There are, of course, different kinds of proteasome inhibitor. You just heard from Dominique about carfilzomib, which is down here is in a reversible proteasome inhibitor. Means that some of these drugs bind the proteasome forever in a way. They always get stuck to it, while other, like the Velcade, you're probably more familiar with, was a reversible proteasome inhibitor, and also Ixazomib, the one we are focusing our attention, and here you can see in red, is also another reversible proteasome inhibitor, meaning that they can attach to the proteasome but also are able to dissociate from it. And this is important because may explain some of the toxicity and why this drug is probably a bit better than Velcade. But let me review with you some of the clinical data that may bring the approval also in Canada about this drug. So this drug has been tested for the first few years ago for the first time in a newly diagnosed myeloma patient. You can see that when there is a new drug developed by a company, they have to go through different phases of clinical trial, phase 1, phase 2, and phase 3. And these are showing some data of the phase 1 and 2. These are the phases essential because we need to know the dose we can use as much. I mean, we have obviously to start with a very low dose and understand the higher level without having activity, without causing toxicity. And you can clearly see that this drug is unique because, first of all, is an oral, is a pill. The patient can take once a week, 3 times in a row, 3 weeks in a row. And this drug was combined in this specific trial with Lenalidomide, the IMiDs you are probably very familiar with, that need to be taken for 21 days, usually 25 milligram daily. And that was associated with Dexamethasone. Nobody really, I know from your perspective, nobody likes Dex, but somebody said Dex is like bacon, work very well and I have to say, in all the combination is always there because make our drug more effective. What we have learned from this initial study that this drug was actually safe, didn't cause any toxicity. There was some drop in the platelets, but nothing major. More importantly, didn't cause any neuropathy. And the neuropathy was actually 3%. Really, only 3 among 100 patients had this tingling and numbness that unfortunately for Velcade is a major problem. And then was effective. The efficacy, the overall response rate that for us tell us how the patient respond to the drug was 92%, meaning if we have 100 patients, 92 of them respond. So very encouraging result. And now there are other trials where this drug has been used as a maintenance. You can tell since it's an oral drug, seems to be tolerable, can be used also for longer time, and we will learn in the next few years about this trial. These trials are still ongoing. What about relapsed refractory myeloma? I have to say this population are the one we usually choose to test a new drug because this is where we have the major need. These are patients when they fail Velcade and also IMiDs, we don't have a lot of option. Although I have to say in this session you will learn more about also immunotherapy, so we are not really running out of option, but this drug was one of them that we could be using in this setting. So again, was initially the dose needed to be determined, and also in this population, so they start a different dose of the drug, again weekly for 3 weeks, and then we identified the dose was 2.97 was safe, and in this small study we saw some sign of activity. Again, we're talking about just single agent, we didn't combine with anything at this point. And again, safety profile, so nothing really, no major toxicity that were identified. And that led to a big study. This is a phase 3 study. This probably the study will allow Ixazomib to be approved also in Canada. It's a study where more than 700 patients with relapsed refractory myeloma were randomized to receive either this drug, we can call study drug, plus Len-Dex in the schedule I was mentioned before. Again, MLN weekly, Len was given continuously for 3 weeks, and Dex weekly. It was compared what we think was the standard of care at that point. It was actually Revlimid Dex plus a placebo. This was an interesting study, was double blind, meaning we didn't know what we were giving to the patient. The patient didn't know if he was taking the study drug or the placebo. Placebo is basically an empty tablet. Why we did that? Because we didn't want to be biased on analyzing the data, and the patient also didn't need to be biased on reporting us toxicity. Was a very large study that actually enrolled a patient that of course need to have diagnosis of myeloma, and they actually allow patients with a free light chain only to be part of the study. Dominique reports some of the other criteria for the ASPIRE. Sometimes these patients are unfortunately not eligible for the trial. So it was kind of open to all kind of comers in a way. They of course didn't have to be multi-refractory, so they should have just only 3 line of therapy. They could have been having a refractory disease, so disease resistant to drug. The only thing we could not really the patient have was a refractiness, so in a way resistant to a proteasome inhibitor. So because you can imagine at the end of the day is an oral proteasome inhibitor, so we this was the only exclusion criteria. The other things too that was nice to see, at least for us when we have new drugs, is also we want to make sure that the 2 arms we are comparing are balanced. And balance means they need to have, first of all, same number of patients, but also the characteristic of the patient in terms of staging needs to be the same, in terms of prior therapy should be the same, and more importantly, cytogenetically. We told you today about these bad features in a way. Some patients have this deletion 17, they unfortunately have an aggressive disease. So in this study, they tried to balance the 2 arms, putting the same number of patients with the high risk in both arms. What was very nice to see, and you can clearly appreciate on this curve, that patients receiving the study arm, showing here in red, they have a better survival. They actually they have a PFS, what we call for you is like an outcome, so 26 months versus 14.7 months. So you can really see 6 months of difference if you are on the study drug versus no drug in a way. And then this was the response rate. If you look at in the left side first, the overall response rate, meaning the kind of response the patient had was much higher if you received the 3 drugs versus only Revlimid Dex. This was true for all patients, but also was true for patients with standard risk, and more importantly, patients with deletion 17p that I told you are unfortunately have an aggressive disease. For 14, they actually benefit from it. And the true actually was the proof of it was actually showing when we look at the progression-free survival. You can obviously see difference when we treat patients with the standard risk. 15.6 months versus 20 months. But in patients with high risk, we actually have patients surviving much, much longer, although they have these high-risk features. And this also tells us that probably with this drug, we may overcome some of these bad features that some of these patients have. So this data was quite nice and impressive. And again, just reviewing with you some adverse events, the two arms were equally in terms of number of side effects. There was not a surprise to see more thrombocytopenia, so reduction in platelets, because again, this is very similar to Velcade regimen. So we expect unfortunately, the patient on this regimen, they have a lot of thrombocytopenia. And there was no patient, they had to stop the drug because it was too toxic, it was intolerable. So probably say the fatigue is probably one of the side effects, but was overall quite tolerable. So to conclude this big phase 3 trial, again, 700 patients, more than 23 countries, and we were lucky enough to test this drug in our patient too. So we can clearly see that this combination improved the survival of the patient, it's tolerable, and more importantly, seems to be active in this population where unfortunately we don't have a lot of options, the one with the high risk. And I want to just summarize what we think probably we can predict in a few years what will happen. Probably this combination can be a new standard of care for patients with relapsed refractory. As you heard from before, in November, actually, this drug under the name of Nilaro was approved in combination with Revlimid Dex. I can tell you that Takeda, which is actually the company behind this, has already approached Canada, should hear from it about in the next few months, so we will know where we will stand in terms of approval in our country. And I will say probably stand very close in terms of approval where Carfilzomib will be, another drug waiting to be approved. And there you heard about some toxicity of the Carfilzomib, I guess will be our judgment on a way, taking consideration the characteristic of the patient that probably will help us to decide which drug to use in that specific patient. And then I mentioned already the fact that probably this drug can also have a place in maintenance because it seems to be safe and also oral and seems to be also not toxic. So I think I'll stop here and we'll have a question at the end, I believe.